When a child needs surgery, it's understandable that one of the biggest fears for any parent is anesthesia. But what you might not see is that behind that single moment of going to sleep is an entire system, a really carefully built process designed for one thing and one thing only: safety. Today, we're going to pull back the curtain on the clinical guidelines that protect kids every single step of the way. It's a whole system designed from the ground up for them.
So, you might be wondering, what's the big deal? I mean, what really makes putting a child to sleep for surgery so different from an adult? It's a great question, and the answer is actually fundamental to keeping them safe.
And here it is, the core principle of all pediatric medicine. Children are not just small adults. It's so important. Their airways, their metabolism, how they breathe, it all works differently. And because of that unique physiology, they need a completely specialized, systematic approach to safety, from the very beginning to the very end.
And that systematic approach, well, it starts long before a child even gets to the hospital. This first part of the journey is all about preparation, about setting the stage for a safe procedure.
It all begins with a super careful evaluation. Anesthesiologists will do a focused airway exam, looking for things like kissing tonsils. Tonsils that are so large they almost touch, which could make breathing tricky. They also use what's called the ASA classification system. Think of it like a health score, from 1, being perfectly healthy, to 6, being brain dead. This simple score lets the entire team understand and plan for any potential risks right from the get-go.
The system is smart, too. It knows how to focus its resources on those who need it most. So some kids get extra attention and planning. We're talking about infants, children with other serious health problems, kids who just got over a cold, or those who are overweight. Each of these groups gets a specialized plan to manage any potential issues before they even have a chance to start.
Okay, another key part of this prep phase is fasting. Now, the old way was super simple: nothing to eat or drink after midnight, period. But we know now that long fasting times are actually counterproductive. They make kids anxious, dehydrated, and just miserable. So the modern, guided approach shows us how we can keep them perfectly safe from aspiration, but also make the experience way more comfortable for them.
And here are those modern rules. They're clear, simple, and totally based on evidence. Just look at that 2-hour rule for clear liquids. Encouraging a child to drink some water or apple juice up to 2 hours before their procedure, it helps prevent all that distress we just talked about. It's a perfect example of a small, smart change that makes a huge, huge difference.
All right, now we move into the operating room. And in here, the safety system kicks into a whole new gear. It's all about active, constant vigilance, powered by a highly trained team and some really essential technology.
Now, this is a non-negotiable standard, a hard rule. For any procedure that involves deep sedation, you have to have at least 2 people. First, you've got the practitioner who's actually doing the procedure, but the second person, they're the real safety linchpin. They are an independent observer whose only job, their sole responsibility, is to watch the child. They're not helping with the procedure. They are 100% focused on that patient's breathing, heart rate, and overall well-being. And one of the most critical tools that Observer uses is this: capnography. It sounds complicated, but in simple terms, it's a monitor that continuously measures the carbon dioxide in every single breath a patient takes.
So why is this thing mandatory? Well, because it gives instant, real-time proof that air is moving in and out of the lungs. It's the earliest possible warning sign of a breathing problem. It lets the team jump in and fix an issue long before other monitors, like an oxygen sensor, would even show a problem.
And here's a really cool expert insight. While the machine spits out a number, the team is actually watching the shape of the waveform on the screen. A steady, consistent wave is the visual proof, breath by breath, that everything is okay. That continuous flowing signal is actually the most critical safety feature of all.
Let's talk about another area where things have gotten so much better: IV fluids. For a long time, the standard IV fluid's what we call hypotonic, meaning they had less salt than the human body. And this could be really dangerous for kids because all that extra water would rush into their cells to try and balance things out, which would dilute their sodium levels and lead to a serious condition called hyponatremia.
So, because of this risk, the guidelines changed. Today, the American Academy of Pediatrics has a strong recommendation that all kids get isotonic fluids. That is, fluids that have a salt concentration that perfectly matches the body. This one, evidence-based change has dramatically reduced the risk of this severe complication. It has made care so much safer for millions of kids.
So, the procedure's over, but the safety system is still fully engaged. The recovery phase has its own unique set of challenges. And, you guessed it, its own set of protocols all designed to make sure a child wakes up safely.
One of the most common, and honestly one of the most frightening things for a parent to see, is something called emergence delirium. As a child starts to wake up, they can become extremely agitated, even inconsolable. But here's the really important thing to understand. This is a well-known, totally temporary thing. It usually only lasts for about 5 to 15 minutes, and most importantly, it has no known long-term effects. The team's job is just to keep the child safe and comfortable until it passes.
Pain control has also gotten way smarter. Instead of just relying on strong opioids, the modern approach is what we call multimodal. This means using a whole combination of different medications, like non-opioids and regional nerve blocks, to control pain really effectively while minimizing the risks of opioids, like slowing down their breathing. It's all about maximizing comfort while keeping safety number one.
And here is a perfect example of just how proactive this system is. For kids who are at a high risk of breathing problems, think of children with severe obesity or sleep apnea, the opioid doses aren't just tweaked. They are significantly cut right from the start, often by 50% or even more.
As you'd expect, the youngest patients get the most protection. Because infants are at a higher risk for something called apnea, which is just a pause in breathing after anesthesia, there are strict mandatory observation periods. You can see here, the very youngest infants require at least 12 hours of monitoring before they can even be considered to go home. And for babies born prematurely, there is a critical safety number, 60 weeks. An ex-preemie has to be at least 60 weeks post-conceptual age, that's their age at birth plus their age now, before they're considered safe for an outpatient procedure. If they're younger than that, they're automatically admitted to the hospital for monitoring. It's a hard and fast rule built entirely around keeping them safe.
So, as we start to bring this all together, I hope you can see that it's not about one single action, right? It's a comprehensive, multi-layered system that's designed to protect a child through their entire surgical journey.
So, what's the big takeaway here? Pediatric anesthetic safety isn't just one thing, it's a whole process. It starts with assessing risk way before surgery. It relies on a dedicated team doing constant, vigilant monitoring. It uses evidence-based rules to prevent known harms, like with fasting and IV fluids. And it's all precisely tailored to a child's specific age and maturity.
And finally, let's address a big fear that many parents have heard about. This quote is the consensus statement from the experts. And while research is always ongoing, the evidence we have shows that for a single, brief anesthetic, the known and immediate risks of delaying a necessary surgery far outweigh the theoretical concerns about long-term effects.
And that brings us to our final thought for today. This entire system, from start to finish, is built to anticipate and defend against problems that are rare but have very high stakes. And it kind of makes you wonder, doesn't it? What other complex parts of our lives, from technology to transportation, could benefit from this exact same philosophy of proactive, systematic safety design?